Welcome back to the deep dive. Imagine a tiny newborn full of potential whose very first breaths kick off this kind of silent physiological race against time.
Hmm.
For some, that race hits a really crucial hurdle, a tiny vessel that, well, just won't close.
Yeah,
Today, we're diving into that silent struggle known as patent ductus arteriosus, or PDA.
right, PDA.
And this deep dive is tailor-made for you, our curious learner, as we explore PDA and some frankly captivating animals, llamas, alpacas, and deer.
Absolutely. And our mission today really is to cut through the medical jargon,
Yeah.
give you a shortcut to being well-informed.
Oh, sure.
We'll look at what PDA actually is, how it impacts these unique animals, how we diagnose it,
Right.
and crucially, what are the surprising differences and honestly, the big knowledge gaps across these species.
It sounds like a journey that shows how this tiny, temporary fetal lifeline can turn into a really life-threatening problem.
It really can.
We should uncover some genuine aha moments, maybe some surprising facts too. Okay, let's unpack this.
Let's do it.
So, to really get PDA, we need to go back, right back to the beginning, inside the womb. What exactly is the ductus arteriosus, the DA, in the first place?
Okay, yeah. So think of it as a critical temporary bypass system. Every fetal mammal has one.
A bypass. Why?
Well, in the womb, the lungs are filled with fluid. They aren't breathing air yet. So they have incredibly high resistance to blood flow.
Ah, okay.
The DA acts like a shortcut. It connects the pulmonary artery directly to the aorta.
Gotcha.
And this shunts, something like 80 to 90% of the blood away from those unused lungs.
Wow, that much.
Yeah. It makes sure the oxygenated blood, which is coming from the placenta, gets sufficiently to the developing body, and it kind of preps the heart for life outside.
Then comes that really dramatic moment of birth. It's like a physiological ballet, isn't it?
It is a whole symphony of shifts. That first breath inflates the lungs,
Right.
their resistance plummets, and the placenta is removed, all happening incredibly fast.
So what makes the DA close?
It's triggered mainly by two things happening almost at once. First, there's a sharp rise in oxygen in the blood now that the neonate is breathing air.
Okay.
That directly signals the duct's smooth muscle to, contract, clamp down.
And the second thing
The second thing is the placenta's gone. And the placenta was making hormones, prostaglandins like PGE2, that actively kept the duct open before birth.
so the keep open signal disappears.
Exactly. So you've got the close signal from oxygen, and the keep open signal is gone. That combination usually leads to functional closure within hours.
But it's not just clamped shut, right? It actually changes structurally.
That's right. Over days to weeks, it remodels completely. It turns into the ligamentum arteriosum, basically a solid fibrous cord that doesn't carry blood.
Okay, so here's the twist. PDA is when that closure fails.
Precisely. And here's where it gets really interesting, especially comparing to humans sometimes. For full-term domestic animals, dogs are the classic model, but we assume this for many others. PDA is primarily a structural failure.
Structural, what do you mean?
Think of it less like a door that's just stuck shut and more like a door built without the right kind of latch mechanism in the first place. Studies show there's often a deficiency of the proper contractile smooth muscle in the wall of the ductus. It's replaced by elastic tissue, which just doesn't contract properly.
And that structural difference is key for treatment.
Absolutely key. It explains why drugs that can sometimes help close a PDA in premature human babies, where the issue might be more functional, are basically ineffective in these animals.
Right, because the structure itself is wrong.
Exactly. You can't drug a faulty structure into working correctly. They need a physical intervention, something to physically block or tie off the duct.
Okay, so if that duct, that door, stays open after birth, what's actually happening inside the animal's body? Paint us a picture of this continuous left-to-right shunt.
Well, think about pressures. After birth, the pressure in the aorta, the main artery leaving the left heart to the body, is much higher than the pressure in the pulmonary artery going to the lungs.
Okay, makes sense.
So if the PDA is still open, that higher aortic pressure constantly pushes oxygenated blood backwards through the PDA into the pulmonary artery.
Backwards, so blood that just came from the lungs goes right back to them.
Exactly. It's already picked up oxygen, gone to the left heart, got pumped into the aorta, and then a chunk of it immediately shunts back into the pulmonary artery to go through the lungs again.
That sounds incredibly inefficient, like pumping the same water over and over.
That's a great analogy. It's a massive volume overload, especially on the lungs and the left side of the heart.
And all that chaotic flow must make a sound. You mentioned diagnosis earlier.
It absolutely does. That high velocity Turbulent blood rushing through the narrow, open duct creates a continuous vibration.
Continuous.
Yeah, through the whole heartbeat cycle. When you listen with a stethoscope, typically over the left base of the heart, you hear this characteristic continuous washing machine sound, or sometimes called a machinery murmur. It's usually loudest during systole, when the heart contracts, but it persists right through diastole when it relaxes. And often, it's so strong you can actually feel the vibration if you placed your hand on the chest wall. We call that a precordial thrill.
A washing machine murmur and a thrill.
Okay, so the heart's clearly working overtime trying to manage all this extra blood flow.
Exactly. That shunted blood, remember, it's already been through the lungs, gets sent right back. So the lungs get too much blood flow, pulmonary overcirculation, and then all that extra blood returns to the left side of the heart, the left atrium and ventricle.
So they get overloaded.
Chronically overloaded. And to cope, or try to cope, these chambers stretch and enlarge. It's a type of enlargement called eccentric hypertrophy. Think of like an overstretched balloon. The walls get thinner and the chamber gets bigger.
That doesn't sound good long term.
It's not. And as the left side enlarges, the mitral valve, which sits between the left atrium and ventricle, can also get stretched out of shape.
Leading to more problems. Yep. It can lead to secondary mitral regurgitation. The valve doesn't close properly, and blood leaks backward within the left heart itself, making the volume overload even worse.
Okay, what about elsewhere in the body? Any other signs?
Yes. Another classic sign relates to blood pressure. Because blood is continuously running off from the high-pressure aorta into the lower-pressure pulmonary artery throughout the heartbeat cycle, especially during diastole.
Right.
The diastolic blood pressure in the aorta drops lower than normal. This creates a wider difference between the systolic peak and diastolic lowest pressures.
And you can feel that.
You can. It results in really strong, bounding peripheral pulses, usually felt in the femoral artery and the groin. They're often described as hyperkinetic or sometimes water hammer pulses, very snappy.
Okay, so machinery murmur, thrill, bounding pulses, enlarged left heart. If this isn't fixed, it sounds like the heart just can't keep up.
Ultimately, no. Untreated, this relentless volume overload leads to left-sided congestive heart failure, or CHF.
And what does CHF look like in these animals?
The overloaded left heart can't pump efficiently anymore, so pressure backs up into the lungs. Fluid starts leaking out of the blood vessels into the lung tissue itself. That's pulmonary edema.
So difficulty breathing.
Exactly. You see coughing, rapid breathing, what we call tachypnea, and exercise intolerance. They just can't keep up.
What's the prognosis then if it gets to CHF?
It's grim without intervention. In dogs, which are our best studied models, something like 70% develop CHF before they're even a year old.
Wow.
And most will die from it within 1 to 2 years if the PDA isn't corrected. It's truly heartbreaking for owners.
But wait, you mentioned something earlier. There's an even more complex and maybe more dangerous path this can take. The reverse PDA.
Yes, that's Eisenmenger's physiology or Eisenmenger's syndrome. It's a really serious complication.
How does that happen?
In some animals, usually those with a large PDA, that chronic high pressure and high blood flow battering the lungs causes the small pulmonary arteries, the arterioles, to react. They remodel, their walls thicken, they become scarred and narrowed.
So the lungs fight back against the flow.
In a destructive way, yes. This leads to severe, irreversible pulmonary hypertension, dangerously high blood pressure within the lungs. Irreversible. And eventually, the pressure in the pulmonary artery can become so high that it actually exceeds the pressure in the aorta.
Whoa, so the pressure gradient flips.
Exactly. And when that happens, the direction of the shunt through the PDA reverses. Instead of left to right, aorta to pulmonary artery, it becomes right to left, pulmonary artery to aorta.
So deoxygenated blood is now getting into the systemic circulation.
Precisely. Blood from the right ventricle heading towards the lungs gets shunted directly into the aorta, bypassing the lungs entirely.
And the clinical signs must change dramatically then. What happens to that machinery murmur?
It disappears because the flow pattern changes. That continuous turbulent jet is gone. So a vet listening might think the PDA has magically closed, but it's actually become much worse.
So what do you see?
Instead, you might see something called differential cyanosis.
Differential cyanosis, meaning blue in some places but not others.
Exactly. Remember, the PDA connects to the aorta usually after the arteries branching off to the head and front limbs.
Okay.
So the front half of the body, head, gums, front legs, still gets relatively well-oxygenated blood from the left ventricle. Those mucous membranes look pink.
But the back half?
The back half of the body gets blood flow from the aorta after the PDA connection. So it receives that mixture containing the deoxygenated blood shunted from the pulmonary artery. The mucous membranes there, like the vulva or prepuce, will look bluish or purple, cyanotic.
Pink front, blue back. That's quite a sign.
It's a classic sign of a right-to-left shunting PDA. And the really critical point here, absolutely critical, is that once this reverse shunt is established, closing the PDA is fatal.
Fatal. Why?
Because in this situation, the PDA is actually acting as a pressure relief valve, a pop-off valve, for the dangerously high pressure in the right ventricle. If you suddenly close that escape route, the right ventricle faces an impossible pressure load, leading to acute right-sided heart failure and death.
Wow. So catching it before it reverses is absolutely crucial.
Vitally important. It highlights why timely diagnosis and intervention are so key for PDA.
Okay, so given these high stakes, how do we actually nail the diagnosis? What are the key steps?
Well, it often starts with those physical exam findings we talked about.
Yeah.
That classic continuous machinery murmur over the left heart base.
Right, the washing machine sound.
Exactly. Often with that palpable thrill, that vibration, and those strong, bounding, hyperkinetic pulses in the femoral arteries. Those three things together are highly, highly suggestive of a left-to-right PDA.
What comes next? Imaging. Maybe chest x-rays.
Yes, thoracic radiography or chest x-rays is usually the next step. They can show cardiomegaly and enlarged heart silhouette.
Especially the left side.
Especially the left atrium and left ventricle. You might see the trachea push upwards on the side view, which indicates left atrial enlargement. You can also often see signs of pulmonary overcirculation. The lung vessels look too prominent. And sometimes you can even see a little bulge on the aorta where the ductus is, called a ductal bump. And of course, if the animal's already in heart failure, the x-rays will show pulmonary edema, that fluid in the lungs, making them look cloudy or hazy. An ECG, an electrocardiogram, can also provide supportive evidence, showing patterns consistent with left heart enlargement.
But for the definitive slam-dunk diagnosis, I guess you need to actually see the PDA.
That's where echocardiography, ultrasound of the heart comes in. It's really the gold standard.
What does the echo show?
Using 2D and M-mode echo, we can directly see and measure the chambers, so we confirm the dilation, the enlargement of the left atrium and left ventricle.
Okay.
But the real clincher is color flow Doppler. This lets us visualize blood flow in real time, overlaid on the heart image in color. With a PDA, we can actually see that turbulent jet of blood shooting continuously from the aorta into the pulmonary artery. It lights up like a Christmas tree on the screen. There's really no mistaking it.
And what about for those tricky reverse PDAs where the murmur is gone?
Good question. If we suspect a reverse, right-to-left shunt, perhaps because of that differential cyanosis or other signs, we do a specific test during the echo called a bubble study, or contrast echocardiography.
Bubble study.
Yeah, we inject a small amount of agitated saline, basically salty water with tiny microbubbles, into a peripheral vein, usually in a leg. Normally, these bubbles get filtered out by the lungs.
Okay.
But if there's a right-to-left shunt, like a reverse PDA, those bubbles will bypass the lungs through the shunt and appear directly in the descending aorta on the echo screen. It confirms the abnormal connection.
Fascinating. Okay, let's shift gears. From the general principles to some specific and maybe surprising cases, let's talk about South American camelids, so llamas and alpacas.
Right, the camelids.
Now, PDA isn't as common in them as it is in, say, dogs, right? But it's still a pretty significant concern.
It is. It's often cited as the second most common congenital heart defect found in llamas and alpacas, right after VSD's ventricular septal defects, which are holes between the main pumping chambers.
And is there any idea why it occurs in them? Is it genetic?
Well, there's a strong hypothesis, especially for camelids living outside South America, like in North America or Europe. The idea is that these populations were founded from a relatively small number of imported animals.
A limited gene pool.
Exactly. A limited gene pool, a founder effect, could potentially concentrate certain genetic predispositions, possibly including those for congenital heart defects like PDA. It's not definitively proven, but it makes biological sense and is a really critical consideration for breeders.
So what does PDA look like in a baby llama or alpaca cria? Are the signs different?
The underlying problem is the same, so the signs are broadly similar to other species. Very often it manifests as failure to thrive.
Meaning
They just don't grow well. They might seem weak, have stunted growth, poor weight gain. You might see a 6-month-old alpaca cria with PDA that's literally half the weight it should be.
wow.
And crucially, you'll usually find that characteristic continuous machinery murmur and those hyperkinetic bounding pulses if you examine them carefully.
Is there a time frame for closure in Crius, like you mentioned for other animals?
Yes, and that's important for diagnosis. In healthy llama and alpaca crius, the ductus arteriosus normally closes functionally pretty quickly, certainly by about 3 to 4 days of age.
So it's still open after that?
If you can still hear that murmur or detect flow with an echo beyond about 1 week of age, that's generally considered diagnostic for PDA in a crius.
Now, treating something like this in a llama or alpaca sounds challenging, but there's been a real breakthrough, hasn't there? Using something originally for dogs.
It's been a fantastic development. Yes, historically options were very limited. Major open chest surgery on a small cria is risky. But advancements in minimally invasive interventional cardiology have really opened doors.
And the specific breakthrough.
It's the successful closure of PDA in both llamas and alpacas using a device called the Amplot's Canine Duct Occluder, the ACDO.
Canine. So it was designed for dogs.
Exactly. It's a self-expanding mesh device delivered via catheter, designed specifically for closing PDAs in dogs. But veterinarians realized that the anatomy of the PDA in some camelids might be suitable for this device.
How do they do it?
It's done under fluoroscopy, which is like live X-ray imaging. They first perform angiography, injecting contrast dye to map out the exact size and shape of the ductus.
Like measuring it up.
Precisely. For example, in one Polish alpaca case, they identified what's called a type IIA ductus morphology, which turned out to be a good fit for the ACDO. They guide the catheter carrying the folded device through the blood vessels, position it within the PDA, and then deploy it. The mesh expands and plugs the hole.
That's incredible. Using a dog device in an alpaca, what does that mean more broadly?
It's a huge paradigm shift, really. It shows that instead of needing a unique species-specific device for every animal, which is often impractical and expensive, clinicians can ask, what's the specific anatomy of this defect in this animal, and which available device, regardless of what it was originally designed for, provides the best fit?
That opens up possibilities for lots of other species too, I imagine.
Immense promise.
Yeah.
Especially for zoological medicine or other non-traditional species where developing custom devices just isn't feasible.
And what's the outcome for these llamas and alpacas after getting the ACDO? What's the prognosis?
With successful occlusion, the prognosis is excellent. It's considered curative.
Curative.
Yes. It completely eliminates that damaging volume overload on the heart and lungs. The heart can then remodel, often shrinking back towards a normal size and function over time. These animals can go on to live perfectly normal, healthy lives without any further cardiac issues from the PDA. It's a fantastic outcome.
Okay, from a success story in camelids to, well, almost a blank page. Let's talk about cervids now, the deer family. White-tailed deer, elk, moose, etc.
Right. And this is where the contrast is really stark.
It's stark how?
Because compared to dogs, or even camelids now, the scientific record, the published information on PDA and deer is, well, it's profoundly sparse, almost non-existent.
Really? Like, how sparse?
The most direct piece of evidence I could find in the sources was a single, very brief conference abstract. It mentioned successful surgical management, so open chest surgery of PDA in one animal, a female neonate white-tailed deer weighing 2 kilograms.
2 kilograms? That's tiny, like 4.5 pounds. And that's it.
That's pretty much it. No detailed case reports published in journals, no studies looking at prevalence, nothing on diagnostics or other treatments in deer specifically. It's basically a knowledge desert.
Wow. So how do we even approach this then? If a vet suspects PDA in a fawn, what do?
We have to extrapolate.
We have to extrapolate heavily, yes. Based on the fact that cardiovascular physiology is remarkably conserved across mammals.
Meaning hearts and vessels work roughly the same way?
Broadly speaking, yes. So we can be pretty confident that PDA in a fawn would cause the same underlying problems. That left-to-right shunt, the volume overload on the left heart and lungs, the eventual left-sided cardiac remodeling, and ultimately the risk of congestive heart failure if untreated. And the clinical signs would likely be similar too.
We'd expect them to be. Things like poor growth, maybe weakness, failure to thrive compared to siblings, and if you could examine it closely, you'd almost certainly expect to hear that characteristic continuous machinery murmur.
So why? Why is there this massive knowledge gap? Why don't we see more reports?
There are probably several contributing factors, mostly related to observational biases.
Such as?
Well, think about wild populations. A fawn born with a significant hemodynamically important PDA is going to be weaker, slower, less able to keep up with its mother.
Right. Easy prey.
Exactly. They'd likely fall victim to predators or succumb to environmental stresses very quickly. They simply wouldn't survive long enough to be observed or studied.
Okay, that makes sense for wild deer. What about deer in captivity, like in zoos or breeding facilities?
Even there, it's tricky. A young fawn that's just not doing well, a poor doer, might unfortunately die or be euthanized without getting a full, definitive cardiac workup.
Especially if it requires specialized diagnostics like echocardiography.
Precisely. And even if a necropsy, a post-mortem exam, is performed, unless the prosector is specifically looking for congenital heart defects and meticulously examines the great vessels around the heart base, a small PDA could easily be missed.
And I guess general wildlife health surveillance has bigger fish to fry.
Generally, yes. Wildlife disease monitoring understandably focuses on population-level threats, things like chronic wasting disease, CWD, in deer, or epizootic hemorrhagic disease, EHD. Individual, relatively rare congenital heart defects just aren't typically on the radar for broad surveillance programs.
So what are the real-world implications of this knowledge vacuum? Does it matter if we don't know much about PDA in deer?
I think it does, especially in certain contexts.
Okay.
Consider valuable captive breeding programs, perhaps for endangered or threatened cervid species.
Right.
In that situation, failing to diagnose a potentially treatable condition like PDA could mean the unnecessary loss of a genetically important individual. That one fawn could represent valuable genetic diversity for the population.
So we might be losing animals that could potentially be saved if we just knew to look for this.
It's certainly possible. It really underscores a critical need for increased awareness among wildlife veterinarians, pathologists, and researchers. We need folks to perform really meticulous cardiac exams during necropsies of neonate cervids that die unexpectedly.
And to publish what they find.
Absolutely. Even single-case reports are incredibly valuable when you're starting from almost zero. We need that foundational data.
Okay, let's try and connect the dots now. We've looked at dogs as the model, camelids as a success story of applying that knowledge, and deer as, well, the unknown frontier.
That's a good way to put it. Dogs are the reference standard, deep understanding, refined therapies. Camelids show successful clinical translation, adapting canine principles, and even devices. Cervids represent the edge of our knowledge, where almost everything is still speculation based on other species.
And even though the basic problem, the open duct, is the same, the specific details must matter a lot, especially for treatment. You mentioned the PDA shape in that alpaca case.
Critically important. The morphology of the PDA, its length, its narrowest diameter, the angle it comes off the aorta, whether it's funnel-shaped or tubular, all these details dictate which interventional device, if any, might fit properly.
So the ACDO worked for that alpaca's type IAA ductus.
Right, but other shapes might need different devices or might only be suitable for surgical ligation. For cervids, just characterizing these common morphologies, maybe using techniques like CT angiography on postmortem specimens initially, would be a huge step forward for planning potential future interventions.
And body size must throw another wrench in the works, right? That white-tailed deer fawn was tiny, but what about treating an adult elk or moose with PDA if such a case were ever found?
Exactly. Size presents enormous challenges at both ends of the scale. While that 7-kilogram Alamocrea was successfully treated with catheterization, imagine trying to do the same procedure on a several 100-kilogram adult elk.
Yeah, the equipment alone.
You'd need specialized, large animal facilities, longer, larger bore catheters, appropriately sized occlusion devices, which might not even exist commercially for that scale, heavy-duty imaging tables that can support the animal's weight and allow the X-ray equipment to move around it.
And anesthesia must be a major hurdle, too.
A huge consideration. Anesthetic protocols need to be very carefully adapted and monitored for large, wild ruminants, which can have unique physiological responses and risks compared to domestic animals or even smaller camelids. It's definitely not trivial.
So let's quickly recap the general treatment strategies, regardless of the species, assuming intervention is possible.
Okay. First, if an animal presents in active congestive heart failure, you need to stabilize them medically before attempting a definitive fix. That usually involves drugs like diuretics. Furosemide is common to get rid of the excess fluid.
Right.
Maybe ACE inhibitors to reduce workload on the heart, or sometimes pimobendan, a drug that helps the heart contract more effectively and dilates blood vessels.
Get them stable, then fix the hole.
Essentially, yes. For the definitive fix, interventional occlusion using catheter-delivered devices like the ACDO has become the preferred method in many cases where it's feasible. It's minimally invasive, generally has high success rates, and quicker recovery times.
But surgery is still an option. like in that deer case.
Surgical ligation, physically tying off the ductus through an open chest approach, remains a highly effective and curative option. It might be preferred for very small patients where catheters are too big, or for animals with unusual ductus shapes not suitable for devices. And as we saw, it was the only documented treatment reported in a deer so far.
Okay, so looking ahead, what are the next steps? Where does research need to go for these different groups?
For camelids, I think the need is moving beyond just publishing interesting case reports. We need larger-scale studies, epidemiological studies to understand the true prevalence in different populations, and ideally, genetic investigations to nail down that suspected heritability and maybe identify specific genes involved.
Help readers make informed decisions.
Exactly. For cervids, though, the needs are much more fundamental. We're still at the stage of basic descriptive research.
Just finding out what's there.
Yes, publishing those crucial case reports, encouraging meticulous necropsy examinations focused on the heart in young cervids, conducting basic anatomical studies to describe PDA morphology in different deer species. We need to build that foundational knowledge base from the ground up.
We've really covered a lot of ground here, from the tiny details of the fetal heart all the way to the big challenges in wildlife cardiology. It's truly amazing, isn't it, how this one small vessel, so absolutely vital before birth, can cause such huge problems if it just fails to close on cue.
It really is. And what's fascinating, I think, is seeing how our deep knowledge in one species, like the dog, can directly help us save lives in another, like that alpaca.
Yeah.
But it also throws into sharp relief just how much we don't know, especially when we look beyond our domestic animals and into the health of wild populations. The deer situation is a perfect example of those vast unknowns.
So for you listening, maybe the next time you see a majestic deer stepping out of the woods or a curious alpaca peering over a fence, you won't just see their beauty. Perhaps you'll also pause and ponder the invisible physiological stories unfolding inside them. It really makes you wonder, doesn't it? How many conditions like PDA, maybe treatable ones, just go completely unseen, undiagnosed in nature, silently shaping the health and survival of the populations we observe?
Absolutely. It's a humbling thought. This deep dive really shows us that even with conditions we think we understand well, like PDA, there's always more to learn, more connections to make across species, and definitely more questions to ask. And who knows? Perhaps you, the listener, will be part of bridging some of these knowledge gaps in the future.
That's a great thought to end on. Thank you so much for joining us on this deep dive. Stay curious, stay informed, and we'll catch you on the next one.